Well, thanks everybody for joining this session. It's my pleasure to introduce Dr. Jacob Pendergrast, and who graduated from Dalhousie Medical School in Halifax and completed his training in hematology and transfusion medicine at the University of Toronto. Before taking a staff appointment at the University Health Network and serves as the medical director of blood transfusion service. He also works as a clinical hematologist and has been treating patients with hemoglobinopathies, including sickle cell disease, at the Toronto General's Red Blood Cell Disorders Clinic since 2004. At the University of Toronto, he is ranked associate professor in the Department of Laboratory Medicine and Pathobiology with a cross appointment in the Department of Medicine. I'm looking very forward to Dr. Pendergrast's talk about hyperhemolysis and sickle cell disease. Over to you.
Thank you so much, Rob. And thank you to the other conference organizers for putting this together and for those who are in attendance. And my objectives quickly are just to go over what hyperhemolysis actually is, what it looks like, what the risk factors for it are, what the pathophysiology of this condition is, and importantly, once you have recognized it, how to treat it, and then hopefully how to prevent it. These are my disclosures. Okay. I'm going to start off with a case description. It's a young woman with sickle cell disease. She has been transfused several times in the past, typically episodically, not on a chronic transfusion program. Last transfusion was about 7 years ago. And she comes into hospital with what starts off as a pretty typical vaso-occlusive pain crisis. And then she becomes progressively more and more anemic. Her hemoglobin starts to fall. And we get ready to transfuse her. And we discover that she is going to be difficult to transfuse. She has an antibody called an anti-little e, which automatically disqualifies 98% of our blood supply. Just matching for that is going to be difficult. But on top of that, she has made a variety of other antibodies from previous transfusions. And I won't read them all off here, but clearly it is going to be very difficult to find compatible blood for this person. So we initially decide to hold off on transfusing her. We're treating her supportively, making sure her pain is well managed, making sure she's well hydrated, keeping her on oxygen. And her hemoglobin kind of sits around the 50s. And you can see that she's got a fairly high reticulocyte count. So she's making a lot of blood, but breaking it down fairly quickly as well. And so that's why her hemoglobin tends to kind of be quite low. So rather than transfuse, we put her on erythropoietin and we give her a very aggressive dosing because we know sickle cell patients need much higher doses of erythropoietin than other patients in order to get a response. We put her on 40,000 units every single day. But clearly this is not working. Her hemoglobin is now drifting into the 40s. And then very concerningly, she becomes hypoxic, febrile, and we get a chest x-ray and she's got infiltrates. And this looks like acute chest syndrome, which is a deadly complication of sickle cell disease. And the standard of care for this is to transfuse. So after a lot of very careful selection of blood, a lot of very elaborate extended testing, which I won't go into the details of here, we decide to transfuse her. And we give her 2 units. And she has a great response. Her hemoglobin is now up to the 70s. The erythropoietin is now kicking in. So we're having her reticulocyte count is now quite high, to the point where we're almost worried we're going to overshoot, that her hemoglobin will go too high, which can also be dangerous with sickle cell disease. Sorry, just seeing if there's a, okay. And I will definitely take questions at the end. So at this point, we hold the erythropoietin. Her reticulocyte count comes down a little bit, but her hemoglobin stays up. So it looks like through very, very careful selection of blood, we have recovered her hemoglobin, her acute chest syndrome is improving, and we're out of the woods. And at this point, we put her back on hydroxyurea in order to consolidate our gains, keep her fetal hemoglobin up, and hopefully prevent her from having a chest crisis or other complication down the line. It's not going to kick in right away, obviously. And then her hemoglobin begins to plummet, and with it, her reticulocyte count. And it's not the hydroxyurea. The dose we're putting her on is not high enough to do this. And we're seeing signs that she's beginning to hemolyze at an accelerated rate. Her LDH, which is an enzyme within red blood cells, is starting to climb, showing that her red cells are breaking down at a faster rate. And now we do another group and screen, and now there's a new antibody, an anti-N. And this is not an antibody we normally worry much about in transfusion, but clearly it's causing problems for her. And her direct antiglobulin test is negative, suggesting that the N positive unit that we presumably gave her is now gone. It's been hemolyzed away. And we see some other worrying signs. Her platelets are falling. Her ferritin, which is a marker of macrophage activation, although it may have some other significance that we'll get into, is extremely high. Her complement levels are low, and her lactate is very high. At this point, we recognize this as hyperhemolysis, and I'll get into what that means exactly. But what it means at this point is that we cannot transfuse her, at least not without a lot of precautions. So we put her back on the erythropoietin. We start her on steroids and IVIG in order to try to tamp down her immune system and hopefully stop the rapid destruction of blood. Her hemoglobin falls even further, now down into the low 30s. At this point, we're in big trouble. And we know that to transfuse her, in order to keep her from making new antibodies, from destroying the blood that we're going to transfuse, we have to give her a very potent immunosuppression agent, which is rituximab. And with this, we get ready to transfuse again, and hopefully we can rescue her from this. But now her hemoglobin is into the 20s. Her LDH is sky high. And you can see that her reticulocyte count is very low. It's too late. And we lose this patient. This is an absolutely devastating complication of transfusion therapy for sickle cell disease. And it's one that anyone who treats patients with sickle cell needs to be aware of, needs to be able to recognize it when it's happening, needs to know a patient who has had this happen to them in the past so that you don't re-trigger them again with future transfusions. This patient ended up having an autopsy. And in the autopsy, the liver was found to be filled with sickle cells. And what that suggests is what we already know about hyperhemolysis, is that it's not simply that you are destroying all the blood that you have transfused. There's also a rapid destruction of your own blood. The patient's own blood is being destroyed at a rapid rate. That's part of the syndrome. This is what we assume happens with a typical delayed hemolytic transfusion reaction. So a patient who is exposed to blood from transfusion, from pregnancy, from something, makes antibodies to it. That's the primary response. Usually that's not enough to cause problems. The red cells survive that initial immune response. But then those antibodies decrease in titer. We can't see them when we're doing our cross matches in our groups and screens. And then we inadvertently re-challenge the patient with red blood cells that have the same antigen that they made antibodies to. And then you have a secondary response, an anamnestic response, a memory-based response. And the antibodies come back at much higher levels with much higher avidity. Now we can see them in the group and screen. Or if we do a direct antiglobulin test, we can see that the blood that we have transfused is now coated with antibodies. And at this point, the blood begins to hemolyze and break down. And that's hemolysis. And we can see that with a high bilirubin, a high LDH, the hemoglobin falls. That's a typical delayed hemolytic transfusion reaction. Hyperhemolysis is something different. Hyperhemolysis is like a delayed hemolytic transfusion reaction, except that the hemoglobin comes back even worse than before you transfused. And one of the ways that you can see this very clearly in sickle cell patients is to look at their hemoglobin electrophoresis results. And what you will see is that not only is their hemoglobin falling, but the hemoglobin A, which is the blood that you've transfused, is falling at an especially fast rate. And that's a really important part of diagnosing this condition, is doing serial hemoglobin electrophoresis. The LDH is a sign of hemolysis, often gets quite high. The reticulocyte count gets low. Very importantly, patients will initially present not with anemia. That will come later. They will first come to the hospital with what looks like a pain crisis. But after they've been admitted with what looks like a pain crisis, then their hemoglobin falls. Then you see this increased destruction of the red blood cells. And at that point, you know that your patient is in trouble. It's got a high mortality rate. And if they survive, the likelihood of this happening with future transfusions is high. And most importantly, there's one thing that I want to emphasize to the physicians in the audience. You may not see new antibodies when this presents, particularly when it presents acutely. In those cases, it'll look like that nothing happened for the previous transfusion. You won't see any signs of those antibodies. The only way that you'll know that they are destroying the blood that you transfused is by doing those serial hemoglobin electrophoresis. That's a really important test. So the bottom graph here is like that graph I showed you before. This is your typical delayed hemolytic transfusion reaction. A primary response, the antibody drifts away. A secondary response, the antibody comes up very high. With a delayed hemolytic transfusion reaction, you'll see the hemoglobin A, the blood that you transfused, rapidly clear from circulation. With hyperhemolysis, the patient's own blood begins rapidly clearing, such that the total hemoglobin is worse than when you first transfused. That's what makes it hyperhemolysis. You're hemolyzing more than the blood you transfused. The patient's own blood is being rapidly destroyed. And very importantly, in many cases, you will not see that antibody. For whatever reason, we just don't see it. So if you suspect that your patient is having hyperhemolysis, and signs of that would be dark colored urine, which could be due to hemoglobinuria, the free hemoglobin from the red blood cell being passed in the urine, high LDH, worsening anemia, and very often pain is initially how they'll present. You should check to see if there's an antibody, do your group and screen, do your direct antiglobulin test. But most importantly, you should be doing a hemoglobin electrophoresis and looking to see how much of the blood that patient was transfused a few weeks ago is still there. And there's a nomogram, which you can use to kind of determine, is it falling faster than you would expect it to? And if it is, that suggests it's a delayed hemolytic transfusion reaction. And if the total hemoglobin falls to less than what you started with, that's hyperhemolysis. This is an example of how you can actually use this nomogram. And this is available online, developed by Dr. Makansa Tasap. And you plug in the hemoglobin and hemoglobin A percentage, initially drawn right after the transfusion that was given previously. And then when they first come in with what you suspect is a delayed hemolytic transfusion reaction. So here we have a total hemoglobin of 90. The hemoglobin A was 74% after the transfusion. Come back a few weeks later, total hemoglobin has fallen to 28, and the hemoglobin A is down to 50%. This person would be an intermediate to high risk of having a delayed hemolytic transfusion reaction. And you can find this nomogram by just Googling. You could just say hyperhemolysis or delayed hemolytic transfusion reaction nomogram, and you'll find it online. So what is going on? What is happening pathophysiologically? One thought, and this is probably still the case to a certain degree, is that the patient's macrophages, which is sort of the, literally the cell that eats everything, are being highly activated by something. Something is highly activating those macrophages, and they are destroying both the transfused blood and the patient's own blood through mechanisms that don't require binding to antibodies. There are various other cellular adhesion molecules that can be expressed. Various receptors for those exist on the macrophages, and they are eating up blood through both non-immune and immune-mediated mechanisms. What would cause these macrophages to do this? What are they reacting to? We don't know, but there was a study done a few years ago where plasma was collected from patients with sickle cell disease, either at baseline, between crises, during a crisis, or during a delayed hemolytic transfusion reaction. And they took that plasma and they incubated it with normal red blood cells just to see what would happen. And they found that the normal red blood cells were damaged by something in that plasma, some plasmatic factor. And they could tell that they were damaged because they were expressing phosphatidylserine, which is normally not expressed at high levels on healthy red blood cells. And it was like they were being aged somehow. Something in the plasma was aging the otherwise healthy red blood cells that it came in contact with. What that stuff was, what that substance in the plasma of a patient having a delayed hemolytic transfusion reaction was, we don't know. It didn't look like it was an antibody. Couldn't see an antibody. But whatever it was, it appeared to accumulate over probably between 1 to 3 weeks after the patient was transfused, this plasmatic substance. One thought is that whatever it was that was in the plasma that was aging the red blood cells that it came in contact with was related to labile plasma iron. And this is a study that was done for different purposes, but it did show that when you transfuse older blood that has more free iron in it, that leads to more extravascular hemolysis. So higher bilirubin, which can be taken as a rough indicator that a macrophage has eaten that red blood cell and metabolizes hemoglobin into bilirubin. But it doesn't lead to increased intravascular hemolysis, which is typically seen by a change in your LDH, which is an enzyme inside red blood cells, or by a fall in haptoglobin, which is a molecule which scavenges free hemoglobin. So one thought was that, well, maybe what's happening is that during a delayed hemolytic transfusion reaction, labile plasma iron is being released into the plasma, and that is somehow activating macrophages. And once those macrophages have been activated, they just start eating everything. The transfused blood, the patient's own blood, doesn't require binding to an antibody, but something has activated those macrophages, made them angry. And maybe what that something was is labile plasma iron. And one of the signs that this is happening is an increase in your serum ferritin. Ferritin is released by macrophages when they're activated. But there's another way of interpreting the spike in ferritin that we often see in hyperhemolysis. Maybe it's not that the macrophages are being activated. Maybe this is literally the rapid breakdown of the heme molecule, which is being released from a hemolytic red cell. So heme is part of the hemoglobin molecule. It's the part that has the iron within it. You can see in this little diagram, there's a little iron molecule in the middle of the heme molecule. And maybe the heme being released into the circulation is actually the problem, not the iron per se. Why might we think that? Why might we worry about heme being the problem? Well, heme does a lot of interesting things when it's released into the plasma. One of the things that it does is that it actually changes the activity of antibodies that are already circulating, and it broadens their reactivity. It takes an antibody that used to be very specific for a particular target antigen, and suddenly it can start binding to all sorts of other things. And this is thought to be sort of an emergency response, that when there's free heme, that indicates that there is something rapidly destroying red cells, and it's time for your antibodies to become more broadly reactive, not quite so specific. so that they can clean up cellular debris, they can scavenge, bits of bacteria, things that they don't normally weren't targeted for. But this can also lead to autoimmunity. And one of the things that we see with hyperhemolysis is although a third of these patients will have a new antibody against the blood that we just transfused, the way we would expect them to with a delayed hemolytic transfusion reaction, about as many patients will develop what look like autoantibodies or antibodies of unknown significance or a complex mixture of antibodies, sort of a muck of antibody reactivity. Again, you can see that a good portion will have nothing at all. But of those who do have antibodies, a lot of them seem to have this kind of broadly reactive, non-specific kind of pattern. And this is the antigram of the patient that I started this talk with. And if you know how to read these antigrams, you can see that the patient's plasma is reacting with all the red blood cells in the panel. Not hers, interestingly enough, but a whole bunch of others in a very kind of non-specific way. It's not really an autoantibody, didn't really fit any particular pattern for a mixture of alloantibodies. Certainly this wasn't just the anti-N that we saw. But maybe what this represented was heme binding to her anti-N, which we know she had, and then broadening it so it starts to react with everything. And that's a pattern we see often with hyperhemolysis, this kind of pan-reactive antibody. And perhaps this is the heme modifying her specific antibodies so that they become pan-reactive. But there's something else important about heme. This patient's hemoglobin fell very quickly, much more quickly than you would expect it to be possible if it was simply macrophages eating her red blood cells. Typically, if you have macrophages eating red cells, they can get through a single unit of blood in about 12 hours. Her hemoglobin fell much faster than that. And it suggests that it was intravascular lysis. Intravascular lysis is a much faster process. You can get through a unit in 30 minutes. And there was evidence in her case and in other cases that there was intravascular hemolysis. We could see the hemoglobin in her plasma. It was red tinged. We could see it in her urine, also red tinged. And that suggests that complement was being activated. And the reason we think complement is activated is that complement is a good pathway for intravascular hemolysis. Complement leads to the creation of this membrane attack complex, this hole in the red cell, which then causes the red cell to suddenly expand as it fills with water and then explode. So we do see some signs that this is happening. The complement is being activated. We can see it often in a direct antiglobulin test. We can see that the complement is there, but we can also see that the complement ingredients, the C3 and C4 levels, are being used up. Again, signs of complement consumption. Why is this important and how does this tie into the whole issue about heme? Well, normally complement is activated through the classical pathway where you have antibodies binding to the surface of the red cell. That activates complement. Complement then forms a membrane attack complex. But one thing we know about heme is that it can also activate complement. It can activate it through an alternative pathway that does not require antibodies. And this might explain why you see so much intravascular hemolysis, even when you don't see an antibody. Maybe what's happening is that all that free heme is activating complement. And the complement is then binding to anything. It's not specific to any kind of red cell on the surface of, or any antibody on the surface of a red cell. It's just anything that happens to be around. What you transfused, bystander red cells, the patient's own red cells, what have you. And there have been some studies to suggest that there are some patients who are particularly susceptible to this phenomenon, certain variants in their own complement cascade, which makes the complement pathway a little bit easier to turn on, and therefore perhaps a little bit more susceptible to bystander complement mediated lysis, which may in turn be what hyperhemolysis is. So What is the burden of disease from hyperhemolysis? Well, we've done a study recently at our hospital, University Health Network, and we looked at 804 patients with sickle cell disease, and 19 of those had a history of hyperhemolysis. So 2.4% prevalence of hyperhemolysis in this population. Most of them were transfused once at hyperhemolysis and then never transfused again, which is usually what's recommended. Some patients were re-exposed. We thought, well, maybe we can prevent hyperhemolysis if we're very careful with our selection of blood, if we carefully pre-medicate them, and we were wrong. They had hyperhemolysis again. And again, that's an important takeaway from this. Once you've had hyperhemolysis once, there's a high chance you'll have it again, no matter how careful you are with your transfusions. In this series, we had one patient die, and that's a 4% case fatality rate. I can tell you that since we did this study, we've lost other patients as well. This was a different study done in France. And what they did is they actively monitored for hyperhemolysis. And they did this by making sure that every patient who was transfused had a hemoglobin electrophoresis performed within 48 hours after the transfusion. And that was important because they wanted to see what the baseline hemoglobin A percentage was. And then if those patients came back with any kind of acute presentation, pain crisis, dark urine, fever, anything that brought them into the hospital within the next 25 days, they did another hemoglobin electrophoresis. And if they found that there was a 50% decrease in their hemoglobin A, i.e. the transfused blood, or 30% decrease in their post-transfusion hemoglobin, that was very suggestive that they were having a delayed hemolytic transfusion reaction. And those patients had to be managed very carefully. And despite that fact, and this worked out in their study to a 4.2% incidence of a delayed hemolytic transfusion reaction, they had an overall mortality rate of 11.5%. And again, importantly, a third of these patients did not have antibodies. And that doesn't mean that they weren't having a transfusion reaction. It just means for whatever reason, we don't often see antibodies in sickle patients when they're hemolyzing the blood that we just transfused. So what should you do if you have carefully studied your patient's transfusion history, if you've looked at what their hemoglobin A percentages are doing on your serial hemoglobin electrophoresis, and you concluded this patient is having hyperhemolysis? Well, the one thing that you should do, which is often the hardest thing to do, is stop transfusing that patient. It's difficult because they will be anemic, they will be sick, and you will want to transfuse them. And you may even think, I'll just be very, very careful in the blood that I select. But as I've shown, it doesn't matter. Sometimes, no matter how careful you are, once hyperhemolysis is underway, anything you transfuse that patient will just make them worse. So what can you do instead? You have to somehow increase their oxygen delivery without transfusing them. Now, the simple way to do that is to put them on as high an oxygen fraction as you can. You can drive up their oxygen levels to over 400 millimeters of mercury just by dissolving it into their plasma, by putting them on 100% oxygen with a rebreather, for example. And it's important that you do that without paying any attention to their pulse oximetry, because you're not trying to increase their hemoglobin oxygen binding. That'll already be probably near 100% anyway, because they're so anemic. You're trying to drive their plasma oxygen levels up. And if you want to measure something, you'll have to do an arterial blood gas. But really, you just want to drive their oxygen levels as high as you can make them, at least until the patient feels comfortable. And then at that point, put them on erythropoietin in order to drive their hemoglobin up as high as you can. Should you be adding IV iron to erythropoietin to sort of make it work a little bit faster? As I've hopefully shown, there's some evidence that driving iron levels up in the plasma may be inflammatory and maybe not the best thing you want to do in this situation. What about hemoglobin-based oxygen carriers like Hemopure? These have been tried. These are free hemoglobin solutions that don't have any cell membranes. You don't have to worry about new antibodies being made and that sort of thing. I'm hesitant to use these myself, to be honest. Again, some of these substances will have free heme within them. And again, that might also be contributing to making these patients worse. So I tend myself to use high flow oxygen and erythropoietin alone. And then you have to see if you can shut the process off. So the traditional method, and usually what we do first, is we try to shut off the macrophages. We do this with IVIG and steroids. And we measure the response to those interventions by looking at the serum ferritin. Ferritin is a marker of macrophage activation. So this is an example of hyperhemolysis. You can see the ferritin hit almost 50,000 at one point in this patient. After they were transfused, the hemoglobin is falling. They're clearly hemolyzing. IVIG, methylprednisone, in order to suppress the macrophages, and you can see the ferritin comes down and the hemoglobin comes back up again. So that's usually what we do first. You have to be careful though, because the steroids will often trigger a pain crisis after you stop them. That's a side effect of steroids with sickle cell disease, unfortunately. And you have to be careful that the IVIG can itself cause hemolysis. Typically in non-group O patients, it's usually benign, it's usually delayed onset, but you have to be aware that if you're giving IVIG to a group A patient, for example, that may also cause hemolysis, maybe a different kind of hemolysis, but something that you have to be aware of. Tocilizumab is another anti-inflammatory, and this is another way of trying to shut down your macrophages, as well as your general immune response to hyperhemolysis. It's very expensive. It was discovered to be possibly useful for hyperhemolysis in patients who have hyperhemolysis while they're having a COVID-19 infection, because tocilizumab is used sometimes for COVID-19. And this is a case report of somebody who was not responding to steroids or IVIG, but then got some tocilizumab, and you can see that their hemoglobin came up and their ferritin came down. So that's an alternative you might want to think about instead of steroids or IVIG. But again, this is just case reports, off-labeled use of this product. It's expensive, not something you want to reach for everybody. Something else you could think about for severe cases is rituximab. Rituximab shuts down antibody production, and that's particularly useful if you're going to do it before you transfuse. Is it useful once hyperhemolysis is underway? Maybe. But I think we reach for it mostly if we were about to transfuse again and we want to shut down the patient's B cells so they can't make any new antibodies. Another monoclonal antibody is eculizumab, and this is an anti-complement mediated antibody. So this is something which shuts down the complement cascade, shuts down intravascular hemolysis, and hopefully shuts down the production of labile plasma iron and free heme and all these things that we think are so toxic with hyperhemolysis. And this is a case report where you can see that a patient got some eculizumab and their LDH, which had been very high, rapidly decreased. And as that decreased, the hemoglobin started to come up again. So these are also very important tools to have, but they are immunosuppressive. They both increase your risk of infection. Particularly with eculizumab, you have to make really sure that your patient is vaccinated against meningitis, which is a bacteria that can break through once you've given somebody eculizumab. What about targeting the plasma-free hemoglobin or the plasma-free heme, which we think might be driving so much of this? There are a variety of ways that this has been attempted. Plasma exchange, if your patient is stable enough and not anemic enough to be able to tolerate going on an apheresis circuit, is something that might theoretically help. Something you could also try, if you can get it, would be a haptoglobin concentrate, which will bind up all the plasma-free hemoglobin, or a hemopexin concentrate, which will bind up the plasma-free heme. These are not currently commercially available, but they may be in the future, and this may be the solution to this problem when all else fails, when the IVIG and the steroids have not worked, maybe when the eculizumab itself is contraindicated or not working, then maybe these products will be helpful. Which patients are going to be in trouble? Which patients do you have to really worry about and start looking into getting some of these off-label, very expensive therapies? One case series looked at risk factors for death from hyperhemolysis, and they found that patients who had extremely high bilirubins, that I've converted this from American to standard units, so a bilirubin greater than 170, patients whose platelets begin to fall or whose reticulocytes get extremely low, less than 50, these are patients who are highest risk of death from hyperhemolysis. These are the ones that you might want to start mobilizing these second, third line therapies for. How can we prevent this? Well, the most important thing we can do, because we know that some of these cases are due to delayed hemolytic transfusion reactions, is to carefully select the blood so that it does not trigger an antibody response. This is the kind of stuff we worry about in blood banks. We think about, okay, let's make sure that we're matching for the big C and big E antigen, because we know that most blood donors who are Rh positive express one of those antigens, whereas most Rh positive sickle patients don't. So we want to make sure we're giving C and E negative to patients who are also C and E negative themselves, rather than just sort of giving Rh positive to Rh positive, which is what we normally do. Kel is another one we want to match for, JKB, S, Duffy. All of these are things that the blood bank can do if they know your patient has sickle cell disease, and if they know specifically which antibodies they've made in the past. This is why it's so important, really, when you're transfusing a patient with sickle cell disease, to actually get on the phone with the blood bank. Make sure that they understand this patient has sickle cell disease. Tell them where they've been transfused in the past, what antibodies they may have made that are not currently detectable on your group and screen. As much communication as you can, as early as you can, is important. In fact, if you can genotype your patient, and that's something that all sickle patients should have done at first presentation, then you can get ahead of the game. You can know exactly what type of antibodies they are capable of making and make sure that you selected on that basis. And that's actually more precise and safer than phenotyping. The problem, of course, is that the more specifically matched the blood is for your patient, the more likely you are inadvertently going to be getting an African American or a Black blood donor. And why is that a particular concern? The concern is that as you have higher enrichment of your donors population with Black blood donors, you are also going to increase the risk of exposure to low frequency antigens, because in Black blood donors, these low frequency antigens are not actually low frequency at all. In fact, they're relatively common. And so you may end up exposing your patient to an antigen that they could then make an antibody to, which importantly, you might not then see on your group and screen, because our reagents that we use in blood bank don't typically recognize antibodies to low frequency antigens. And it's perhaps because of this that we see so many cases that look like there's no antibody there. It's because we're not looking for the antibodies that sickle patients will make when transfused with patients with blood from Black blood donors. So when you are considering transfusing a patient with sickle cell disease, it's really important to sit down and carefully assess how risky is it for this person. If you have somebody who is on a chronic transfusion program, who's never had a transfusion reaction, they are low risk. You don't need to worry about them so much. You can give them the usual prophylactic matching of Rh and Kel, and then if they've had an antibody in the past, of course, match for that, and maybe give them a little bit more extended matching too. But these are the ones you don't need to worry about. But if you have a patient who is being transfused episodically, like not on a regular monthly basis, but just here and there during pain crises, during exacerbations of anemia, for surgery, during pregnancy, that's somebody you have to worry about. And then you have to be very careful. You have to go through and look at all the antibodies they have ever made, their historical antibodies. And importantly, that means finding out where they have been treated, which hospitals have they gone to, which ones were they transfused at. Call those hospitals, find out what antibodies they know about. Canadian Blood Services maintains a registry. Call them too. People will report antibodies to Canadian Blood Services, and Canadian Blood Services can then provide that information to you. If your patient has been transfused less than 12 units, they have not been declared safe to transfuse, and they are therefore at higher risk. And if they've ever had a hemolytic transfusion reaction themselves, that also, of course, makes them high risk. And so once you have all these risk scores calculated, If you find out that your patient is high risk, has a score greater than 14, and they have made a clinically significant antibody, then there is a 50% chance, positive predictive value, that they are going to have a high risk delayed hemolytic transfusion reaction when you transfuse them, even if you carefully match them for everything. And these are patients you might actually think about pre-medicating with rituximab, because the risk of delayed hemolysis is so high, and because delayed hemolysis is so dangerous in patients with sickle cell disease. So I will stop at that point. Hope I have a little bit of time to take some questions, and I thank you for your attention.
Thank you, Jacob, for that excellent presentation. I've certainly learned a lot. It's wonderful. So again, just a reminder to the audience, we're supposed to wrap up at 22, but then I noticed that lunch doesn't start until 1:45. I think so we can take advantage of that extra 5 minutes for questions, if the audience doesn't mind. So the first question I have, and so please go ahead and put your questions into the Q&A. One of the attendees who was from Nigeria, had questions about, with limited medical care, what could be sort of a more streamlined approach, or approach that might be potentially useful in that setting?
So I think, speaking specifically about transfusions, I'd say that the most important thing is to make sure that a limited supply of carefully matched blood, which may be the case in in a lower resource environment, and I assume that you're referring to Nigeria itself. One of the most important things you can do is just to make sure that that blood is used very judiciously, i.e., don't transfuse a sickle patient for an uncomplicated pain crisis. Don't transfuse them just because their hemoglobin is low. Those are particularly dangerous, for those patients. The risk of them having a reaction is high. The benefit is likely to be low, but also it ends up using up blood that could be better used somewhere else. And so I think this is an important thing just to keep in mind, that blood is a rare and shared resource for patients with sickle cell disease. And so we all have to do our part to make sure that it's not being used inappropriately and it is being used in the right place. And then there was a question, will I be sharing my slides? Absolutely. I'm quite happy to do that.
And then from Dr. Athali is, does the age of the patient, pediatric or adult, or prior pregnancies increase the risk of hyperhemolysis?
I don't know about data about the age of the patient. I think in general, the more you have been transfused, up until like 12 units, according to that model that I showed you, the higher the risk of hyperhemolysis. And obviously, the older you are, the likelihood that you will have acquired that kind of number of transfusions goes up. So I would say probably older patients are at higher risk just because they're more likely to have made antibodies in the past. That being said, you can find case reports of babies having hyperhemolysis. So it's certainly no protection, young age. Prior pregnancies does appear to increase the risk, if only because of the transfusions that are often given during the pregnancies. I'm not aware of pregnancies that have not been transfused itself being a risk factor. It would make sense, you would be immunized by the fetal blood itself, but that hasn't shown up, probably because so many sickle patients are also being transfused while they're pregnant. So it'd be kind of hard to tease those two things apart.
And there was a question about hydroxyurea. Does hydroxyurea, if you're adherent to your hydroxyurea, does that change the risk of hyperhemolysis?
Well, it definitely does, because one of the things we know hydroxyurea does is it decreases your likelihood of having a pain crisis. It increases your hemoglobin level, and it decreases your risk, therefore, of being transfused. And so being on hydroxyurea means you're less likely to need to be transfused, which is probably the best way to avoid hyperhemolysis. If you're on hydroxyurea and are then transfused, Does the hydroxyurea protect you? Again, I don't have hard data to answer that with, but my gut feeling is no. I would not assume that the hydroxyurea is going to protect you. The best thing the hydroxyurea can do is decrease your need from being transfused in the first place.
And being the moderator, I'm going to take the prerogative of asking my own question. I was fascinated with your high dose EPO every day. So is there, and I got them, I haven't seen, is there good data to show that that actually is effective, and what's the time frame that it starts kicking in?
The only data is just personal experience that many patients who get standard doses of EPO, like 40,000 once a week, or 4,000, 5,000 a few times, during the week, they just don't respond. The hemoglobin doesn't come up. And I'm not surprised in a sense, because we know that, patients with sickle cell disease do have a high degree of underlying inflammation, and inflammation makes you kind of resistant to erythropoietin. So when we've needed a patient's hemoglobin up as fast as we can without transfusing, we've put them on daily doses like that. And typically, even then, you might need to wait like 3 or 4 days before you see a response. Now, for sure, once that response kicks in, you have to watch it carefully and not overshoot. I've seen patients have to have emergency phlebotomies because we drove them up too high. But yeah, for just personal experience, you need higher than normal doses.
Great. And one last question that just came up is about what's the research environment in hyperhemolysis? Is there any promising research that's coming down the road in hyperhemolysis?
At this point, I think the term hyperhemolysis was only coined in the 1990s. So it's a relatively new concept, and we're all kind of sort of getting our head around the case definition of it, and just trying to get the word out there about recognizing it and preventing it. But in terms of like active treatments for it, like clinical trials, nothing that I'm aware of. I think there's a planned trial to sort of quench heme with the hemopexin concentrate, but that's not specifically for hyperhemolysis, I don't believe. I think at this point, what we really need to do to research hyperhemolysis is really get a better sense of which patients are at risk of it, and so that we can, find those patients and protect them before they have this episode. And at this point, we have these risk scores for it, but we don't really know. There's no test to say you're at risk of hyperhemolysis the way you could test somebody to say, you're at risk of anaphylaxis, for example. So I think that's where the research needs to go, but this is a really kind of new area academically.
Great. I'm aware that we're well over time and getting into people's lunch hours, so I'll just close the session at this point. Dr. Pendergrast, there is one question remaining in the Q&A. If you could answer that, type the answer before you leave, that would be great.
Absolutely.
Thanks everyone for participating in all the wonderful questions. Much appreciated.
Okay, thank you.